Ladies and gentlemen, you are welcome to this presentation of a neurodegenerative disorder called Huntington disease. I'm Dr. Prosper Tettey Doe in the United Kingdom. Huntington's disease, the outline would be for this presentation, I'll have a reference, etiology, epidemiology, features, overview, end of life, systematic review, studies and management, and genetic counseling and prognosis. These are the reference material. Huntington's disease is a progressive neurodegenerative condition which presents with motor symptoms, cognitive symptoms, and behavioral dysfunction. The etiology is an autosomal dominant mode of inheritance. It is caused by an expanded CAG repeat in the Huntington gene located on short arm of chromosome 4. It's an abnormal polyglutamine sequence in the Huntington protein. Huntington disorder or disease occurs when the number of CAG repeats exceeds 36, and repeats of 40 or more results in full penetrance of the disease. The number of CAG repeats is also inversely proportional to the age of onset of symptoms at a population level. The pathophysiology, the location of the HTT gene mutation, which was identified in 1993. The pathological mechanism by which the HTT protein causes neuronal cell dysfunction is still poorly understood. The epidemiology shows a prevalence of around 4 to 10 per 100,000 in Western countries, and the mean age of onset is 35 to 44 years, and median survival time is 15 to 18 years after onset. Features of Huntington's disease. The clinical features of Huntington's disease can include psychiatric problems and difficulties with behavior, feeding, communication, and abnormal movements. People can start to show the features of Huntington's disease at almost any age, but most will develop problems between the ages of 35 and 55. The condition usually progresses and gets worse for around 10 to 25 years until the person eventually dies. Signs and symptoms may vary between individuals, and there is no typical pattern. Early features such as personality changes, mood swings, and unusual behavior are often overlooked at first and attributed to something else. Some people with Huntington's disease may not recognize that they have any problems. Behavioral changes are often the first features to appear in Huntington's disease and can be the most distressing. These changes often include the following: lack of emotions and not recognizing the need of others in the family, alternating periods of aggression, excitement, depression, apathy, antisocial behavior, and anger. There is difficulty concentrating on more than one task and handling complex situations. There is irritability and impulsiveness. A person with Huntington's disease may appear to have a lack of drive, initiative, and concentration, making them seem lazy. However, it is just the way the condition affects the brain. Psychiatric problems. Many people with Huntington's disease have depression. This occurs as part of the condition, not just as a response to the diagnosis. And symptoms of depression include continuous low mood, low self-esteem, lack of motivation or interest in things, and feelings of hopelessness. A few people may also develop obsessive behaviors and schizophrenic-like problems, although this is relatively rare. Studies have shown that people with Huntington's disease are more likely to consider suicide, particularly near the time of diagnosis, when the condition is becoming apparent and when they start to lose their independence. There are movement problems in Huntington's disease. Early features include slight, uncontrollable movements of the face and jerking, flicking or fidgety movements of the limbs and body. These move from one area of the body to another and can cause the person to lurch and stumble. These features are often first seen when the person is walking or resting, sitting in a chair, or lying in bed. As the condition progresses, the uncontrollable movements will become more frequent and extreme. However, over time, this may change, and in advanced stages of the condition, a person's movement may become slow and their muscles more rigid. Feeding problems in Huntington's disease presents as weight loss despite having a good appetite, and they can find eating tiring, frustrating, and messy because the mouth and throat muscles don't work properly due to the loss of motor control. In some cases, this can lead to choking and recurrent chest infections. Loss of coordination can lead to spilling or dropping food. Swallowing is a problem, so choking on food and drink, particularly thin drinks such as water, can be a common problem. A referral to a dietitian or speech and language therapist may be necessary if there are difficulties with swallowing. Communication problems and cognitive problems like perception, awareness, thinking, and judgment are affected. And people with this condition often have difficulty putting thoughts into words and slur their speech. They can understand what is being said, but may not be able to respond or communicate that they understand. However, with time, a person with Huntington's disease will become less responsive, more withdrawn, and communicate little. Sexual problems. People with Huntington's disease can have problems with sexual relationships, particularly during the early stages of the condition. This is usually loss of interest in sex or, less commonly, making inappropriate sexual demands. End of life. In later stages of Huntington's disease, the person will be totally dependent and need full nursing care. Death is usually from secondary cause such as pneumonia or another infection. The juvenile Huntington's disease is an uncommon form of the condition that can occur in people younger than 20 years old. Common signs include rapid decline in school performance, changes in handwriting, problems with movements, such as slowness, stiffness, tremor, or muscle twitching, similar to the features of Parkinson's disease, and seizures or fits. The diagnosis is positive family history, characteristic clinical findings, and detection of an expansion of 36 or more CAG trinucleotide repeats in HGT. Treatment. Currently, no treatment to delay progression of the disease. Pharmacological intervention is aimed at symptomatic relief. Systematic review depicts current evidence on pharmacological treatment of motor and non-motor symptoms in Huntington's disease. The results show the following classes of drugs: dopamine, depleting agents, neuroleptics, antiglutamatergic agents, acetylcholinesterase inhibitors, GABA agonists, cannabinoids, antidepressants, and potential neuroprotective agents. Tetrabenazine, a dopamine-depleting agent, was the only pharmacotherapy shown to have a clinically meaningful, satisfactory, significant effect on chorea. The majority of the reviewed studies focus on treatment of motor symptoms of Huntington's disease. In conclusion, the evidence base for the pharmacological management of Huntington's disease is poor. There is a need for future high-quality randomized controlled trials on symptomatic treatment of Huntington's disease, particularly on the pharmacotherapy of non-motor symptoms of Huntington's disease. Pharmacological intervention. The majority of pharmacology therapy is to treat the motor symptoms, aimed at restoring balance of neurotransmitters that are involved in pathogenesis of Huntington's disease, primarily GABA, dopamine, and glutamates. Dopamine-depleting agents such as tetrabenazine, dopamine D2 receptor antagonists, typical and atypical neuroleptics. These are receptor antagonists, dopamine D2, antiglutamatergic agents such as GABA agonists, dopaminergic agents such as levodopa are sometimes used to treat rigidity and Parkinsonian symptoms, occurring most often in the juvenile form of Huntington's disease. The behavioral and cognitive symptoms, one recommends antidepressants such as selective serotonin reuptake inhibitors, SSRIs, acetylcholinesterase inhibitors for memory problems, and neuroleptics, which can be used to treat both psychotic and motor symptoms. Prevention of secondary complications with long-term supportive care and side effects associated with pharmacologic treatments. The agents and circumstances to avoid. L-dopa-containing compounds may increase chorea, alcohol consumption, and smoking to be avoided. Genetic counseling. Children and adolescents with parents with Huntington disease may benefit from referral to a local Huntington disease support group for educational materials and psychological support. In genetic counseling, one needs to have the psychoeducation that HD is inherited as autosomal dominant and offspring of an individual with a pathogenic variant have a 50% chance of inheriting the disease-causing allele. However, asymptomatic individuals at risk may be eligible to participate in clinical trials. Prognostication. Huntington's disease is a devastating progressive disease, and there's no current disease-modifying treatment available. It is crucial that patients receive the most efficacious symptomatic treatment tailored to their individual needs, and also to improve their health-related quality of life. Thank you for your attention.